And merry morning to you. Coming to you today from the studios of Teducation. I'm Ted Jedynak, and today you are going to discover how your universe can be transformed, all through a single bone action process that I'm going to teach you the details of right now. And the reason I'm going to do this is because of this fabulous quote. And what it says, you'll see here, you won't find a new solution in the same old paradigm. So that means if you are going to be looking to do new treatment options or new services for your patients, then you need to look at a new way of tackling that. And certainly in my experience, the field of manual therapies has transformed my profession as an MSK practitioner. So going from a general podiatrist to specializing in manual therapies, MSK medicine since 1996. If there was only one joint or one bone that I could treat with my manual therapy skills, it would be this bone right here. In most Western world countries, we know this as the talus, but also, no, it's not so much Western countries, put my foot in it there. In other countries, some European countries, still refer to this bone as its former name, which is the astragalus. And astragalus, translated Latin astra means star, not crappy Holden car. So you got astra and you got gallus, the galaxy. And so astragalus is literally the star or the center of the galaxy or center of the universe. And that's the theme for today. I had a really interesting experience in the late 90s working closely with a chiropractor, and we were doing a lot of work with postural harmony and postural integrity and really helping people be physically straighter and stronger. While the chiropractor was focusing on the upper body, my role was to look at the lower body. And what I realized was that if the talus was compromised, and this common compensation pattern that we see as podiatrists of pronation, excessive pronation at the subtalar and mid-tarsal joints, it has a direct effect not only locally on the foot, but of course the internal and external rotation of the leg is directly connected to the talus because of the articulation of the talus within the ankle mortise. It's locked in. You cannot have a strong, balanced, harmonious physical posture if the talus is compensating, distorting, or being forced to its end position. And then the dilemma that I had was, okay, well, what does that mean? It means that the talus, because there are no muscles attached to it, there is nothing that the body can do intrinsically to recruit the talus to try and hold and stabilize or pull it back into position. So what that means is the only way, if the talus needs to be mobilized or if it's displaced, the only way it can be improved is from an outside force. And fellow practitioners, today I am your outside force. But this is your role as a practitioner as well. Be the outside force to help with the talus. And there are a number of key reasons why we need to make sure we master the talus. Probably the most key one is post-ankle sprains, post-inversion injuries. The ATFL gets affected in 92% of ankle injuries. But what we know, the evidence is very clear in telling us that post-ankle injuries, the talus is prone to shifting or displacing. In a pronated pattern, you'll get that excessive subtalar joint pronation. The supinated pattern, you get the same thing in the opposite direction. But either way, that has a massive effect on the mechanical integrity of the talus. We know that also the talus and the ankle has a direct impact on the entire lower kinetic chain. We've got to take that into account because problems here at the ankle and the subtalar joint can have a direct effect on the knee, hip, and low back, higher up the chain. The other clear factor is that it's been very clearly shown clinically that helping the talus, improving the talar position, improves your orthotic outcomes. And the reason for that is because if you are trying to control or contain the amount of subtalar joint pronation that's happening, literally your orthotic device doesn't have an effect on the talus, doesn't have a direct contact point on the talus. So therefore, if that's the case, the talus, if it's compromised, will fight against your orthotic devices. And coming up next week, if you haven't already registered for the webinar on improving your orthotic outcomes, do so. You can go straight to footmobilisation.com and you'll find the registration link on there, or have a look right on this Facebook page as well. There's going to be there, and I've just gone off script. So that's a reminder, make sure, or send me a message, ted@footmobilisation.com, if you can't find the link to how to get onto this webinar of improving your orthotic outcomes by 32%. It's going to be a great session next Wednesday. Okay. The other single key factor we need to take into consideration when we're working on the talus is there are 3 sites in the body that have the greatest concentration of mechanoreceptor nerve endings for proprioceptive harmony. The first one is the subtalar joint. The second is the sacroiliac joint. And the third is the temporomandibular joint. And so these 3, I suppose, nexuses, is that nexi, these concentrations of mechanoreceptors coordinate to keep the feet level, to keep the hips level, to keep the head level. And this is all part of postural harmony and good work happening to keep the body mobile and responding to the ever-changing world. So if we have one of those areas compromised, it's going to affect our body's ability to be a strong, balanced, harmonious structure. Our role as lower limb practitioners and foot fixers, we're going to concentrate on the talus. So let us go through the key elements. Today I'm going to go through the clinical clues, clinical tests, the actions, and end range qualities that you need to take care of. Now, I'm just having a little bit of technical issues here. Hello there, Nav.
G'day, Nav.
Nav, Pete the pump. My insulin pump is just talking to me, but I'd rather be talking to you, Nav. Okay, so from a clinical clues perspective, excessive pronation, hyperpronation is the key element. Deltoid ligament test sensitivity. So, when you check for subtalar joint neutral and your patient goes, ow, what, with minimal pressure, that's a clue that there's compensation of the talus and displacement and compensation in the collagenous and ligamentous tissues, particularly the medial deltoid ligament, and also the classic navicular drop. So if you see those clinical clues, there's a fair chance that the talus is going to need some attention. Do some clinical tests. Balancing. So as I mentioned about the proprioception, if this is compromised, your patient's ability to hold, maintain balance, particularly if they're being challenged by looking or closing their eyes, that's also going to be an important clinical test for you. The other one
we didn't see your foot lift up.
Yeah, no, but I'm balancing. Next is the lunge test. So making sure when you do the lunge test that you are handling all of the variables that inevitably your patients will do to try and cheat and win the test and affect your assessment of that test. Okay, so let's get into how do you actually mobilize the talus most effectively. Well, we've got our volunteer taking place on the table. Scully, he's just having a little quiet moment there. Okay, so having your patient in position, and the position is going to be in a prone position. When you set up your patient, make sure that the heel is braced against the table or the chair that they're seated in. The reason for that is we're going to isolate the talus within the ankle mortise. So we need to stabilize the distal part related to the talus, which is the calcaneus, and the proximal part, which is the leg. And the leg weight will actually do that for you. If you have the patient off the end of the table, when you go to mobilize the talus, what will happen is the whole ankle will plantarflex or dorsiflex. And so that will compromise, or it means you won't be concentrating your mobilization force into the talus and its related structures. So that's Ted's tip number 1 for you. The next key element, and with all mobilization and manual therapy techniques, If you only remember one thing, it's these two words: position and precision. Now, the reason for that is if you are, this goes into so many areas of our clinical practice as well, but the key with the talus is making sure your contact points are accurate. So your thumbs on the anterior portion will be on the medial and lateral part of the talar dome in the talar neck, and the posterior aspect will be literally on the posterior parts of the talar dome. So if I was in position here and we're looking posteriorly at my finger positions, that would be where you put your thumb and your fingers. Now, if you think that makes sense to concentrate on the talus by having your thumbs and fingers in an accurate position, give me a thumbs up. Or give me literally a thumbs up, because our thumbs will be the contact point here. And if you have done any talar mobilization training in the past, you'll know the importance of that. If you haven't, let me explain some real fundamental elements here. The anterior section you can feel with your thumbs quite well, but posteriorly it's very difficult to actually palpate the posterior parts of the talus. And the main reason for that is because of all of the soft tissue structures over the that run superiorly to the posterior element of the talus, and the other factor is that it's the area is quite a lot smaller and not so accessible. So you have to a point, guesstimate where that posterior element is. And Ted's tip number 3 for that is just go in the same plane as the plantar aspect of the foot, get your thumbs into position, and then just slide around the malleoli and you will be right into the posterior aspect. So the precision and precision of your contact points are absolutely key. Once you're in position there, then what you're going to do is a gentle mobilization, again in the same plane as the plantar surface of the foot, so the transverse plane. And we are literally going to push 2, 3, pull 2, 3. And when you are pushing, the resistance will come from the table, so you can push against that because the calcaneus is stabilized. But a common trap for young players is when you go to pull or anterior direction, you'll often end up lifting the foot or the leg off the table. So Ted's tip to deal with that is when you push 2, 3, see how my hands are actually rotating. So rather than a push and pull action, you push with a rotation of your wrists and pull the rotation of your wrists. Another important step you can do is stabilize the foot so that it doesn't lift up, and literally by resting your foot on your chest, which is fine if you're male. If you're female, you'll probably generate a lot more business if you do this technique on a regular basis. However, that's one way of being able to stabilize the foot while both hands are working on the talus. You'll generally apply some 3 to 5 kilograms of force, so it's reasonably substantial. If you're not sure how much force that is, get some bathroom scales or kitchen scales and just press on them and you'll feel what 3 to 5 kilograms is, and it's a firm pressure. Again, related to your patient. How big are they? How fragile are they, if we've got those two extremes. You need to apply that mobilization, that cycle. It's almost like a continual mobilization force. Typically, you will do 3 or 6 repetitions. Now, the criteria for that is if you mobilize and you can feel the talus moving, you do that 3 times, great, your job's done. The talar mobilization is taking place. If you aren't feeling the mobilization or the freedom of movement is not coming, you need to repeat another 3 times. So you'll end up doing 6 mobilizations in total. If you still are not getting freedom or release happening in that time, you probably need to look at what other structures related to the talus that may be interfering with that. The other thing is you've got to be mindful of not working on it for 3 hours. I wouldn't recommend that because you'll end up then causing more harm or stress or damage to some of the other neighbouring structures. And as we know, with the Hippocratic Oath, we want to make sure, above all, do no harm. So that's how we would mobilise the talus. Now, have you got a question right there for me right now? I can hear the question. It's coming. It's easing out. Maybe ever since we've got the broadband happening now, I can hear more clearly what people are thinking. But the question is, okay, Ted, yeah, we mobilise the talus, and I'm not too sure about this, remobilising and setting it posteriorly, because the question is going to be what's going to keep it there? And this was a question that actually kept me up at night when I was first working, and again, back to the days with my chiropractor buddy, because they were working on parts of the spine, and then they could recruit muscles to hold and maintain and improve the corrections. With the talus, there are no muscles here. How do we do that? So we worked out an exercise protocol, a releasing, a stretching routine. We looked at the physiology of soft tissue rehab, and we went through a whole lot of processes. I'm going to tell you, there was a lot of experiments, testing, because no one clearly that I could find had established a treatment protocol of how to stabilize the talus for the long term. So we looked at strapping, we looked at orthotic therapy interventions. There's a whole range of things. We certainly go through those options in our workshops because it's a whole subject, and the rehabilitation, stabilization for the long term is a whole field unto itself. Before any of those elements that can be helpful and useful, you've got to have the talus be able to move. See, in a normal unrestricted ankle mortise and subtalar joint, the talus will slide and glide some 4 or 5 millimeters. So it's quite substantial. And if there has been a compromise or past history of ankle injury, it may, in conjunction or independently of a foot that has a high level of pronation, you'll find the talus can anteriorly move very easily, but posteriorly it gets restricted because of the connective tissue restrictions that form over time posteriorly. It doesn't allow the talus to translate or slide back into a posterior direction. So that's where the whole little rehab and soft tissue stuff comes into it. And I want to give a big shout out right now to Alison Fitz from Wangaratta or Benalla or Beechworth. She works in a number of clinics around there. Yeah, I'm being told off here. Alison Fitzgerald, fantastic practitioner, a real great privilege to meet Alison first of all in London. So yes, she travelled all the way across to London to do FMT training with us. Then is going to be joining us in Byron Bay in August for our advanced training as well. But just have something here I prepared a little earlier. This is what Alison found after mastering talar mobilisation. Alison's also gone another step further in using tool-assisted massage for a lot of those soft tissue restrictions, which is what we'll be doing in our advanced training as well. But Alison sent me this message. Ted, chronic sinus tarsi syndrome case was lined up for surgery. Did talar mobs, TAM, tool-assisted massage, last Thursday. She came back yesterday and 50% better already. Woo! Go Al! I don't know if she's called Al, but she is now. 50% better already. She's amazed. I'm amazed, everybody's amazed. This stuff is a game changer. And so that's where people like Fitz, myself, we know the impact that this type of work has on the quality of lives and our patients' lives. So if you have not got foot mobilisation therapies in your toolkit, do something about it. I'd say in 2019, do something new and add that to your treatment repertoire. Shout out to Craig, who did training with us about 10 years ago and is now coming into review. And also, another shout out to Taslim, who's coming from Canada, all the way from Ontario, making the trip. So if any of you in Australia are bitching about how far you need to travel, just think of Taslim. She's making the trip from the other side of the world. So we'll have the links to the workshops. The early bird is expiring at the end of this month. So it's literally Sunday, 31st of March. So it'll be your last chance to save at least $500 on the registration fee. So if you're thinking about it and you're not sure, if this training is going to help you, look, send me a message or go to leave a message on this Mobilisation Therapies page. Ask other people their opinions. Yes, I think it's a game changer. Yes, Fitz thinks it's a game changer. Yes, we think more people should be using this methodology in their clinical practice. Certainly our thousands of patients can be a strong testament to that, and the practitioners all around the world who use this work are getting great results, particularly combining FMT with orthotic therapy. It's kind of like the icing on the cake of orthotic therapy. So I hope this Talar mobilisation lesson has been of service to you. I hope it enables you a way to assess and even treat more patients in ways that you may not have ever done before or considered before. Next session, we are coming back to you tomorrow for a Sunday service. Might be a bit of a Sunday sermon. And we are going to be cracking on. Somewhat, we're doing the cuboid. Yeah, everyone's favourite. But in particular, we're going to be doing the black snake whip. So look out, it's going to be coming to you tomorrow. We might be having a little bit of a sleep in later in the day. But the black snake whip, the cuboid, that's definitely going to be happening tomorrow. So thank you very much for your attendance.
Yeah, you might want to say hello to George.
Oh, hello, George.
And,
yes.
And Brent's on too.
Go, Brent. Brent. How wonderful. Yes, sorry, we were just talking about you yesterday, Brent. So,
we're going to see Brent in Sydney.
Yes, looking forward to seeing Brent. Brent's going to be helping us out in Sydney along with Omar, a couple of FMT specialist practitioners, and Daniel, who will also be helping out. These guys have been specialising in FMT and they're going to be, I don't know if there are any spaces left in Sydney. Sydney's been going, the workshop. There's probably no space left in Sydney anyway, the city. Sydney workshop is certainly leading the race right now. So Melbourne and Brisbane, you better get your skates on. Get in before the early bird expires. So I reckon I would say big thank you. And Brent, I look forward to seeing you in the flesh. We're going to have some fun together and certainly help more practitioners save more souls as well. All right, that's it for me today. Until next time, serve with spirit, consult with care, and check more Taluses today.